The following is a recorded program of an actual stroke support group. The comments expressed are the personal opinions of the participants and not necessarily the opinions of the producers, sponsors, or the broadcasters of this show. This program is not to be used as a way to diagnose or treat any medical condition that you may have. Please consult your doctor or healthcare professional before making any changes to your current medical routine.
Stroke.
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 It comes out of the blue, sometimes without warning.
But those who survive it
should never lose hope.
A stroke can be life-changing.
But it is also
A new beginning.
because for all survivors, there is still a beautiful life after stroke.
Hey everybody, welcome to the show. This is Life After Stroke. I'm Christopher Ewing, and as you guys may know, what we do on this show is basically take a stroke support group and put it on steroids. We put it on the air live for people who aren't able to attend a support group for whatever reason. Maybe it's because of transportation situations, geographical situations, or maybe just physical. Maybe some stroke survivors just aren't able to make it to a support group either near them or anywhere. And so basically we take the support group to you. When I had my stroke almost 8 months ago and then joined a support group, I was amazed at how much information I learned from just being a part of a group. I think that there's just a tremendous amount of information and a tremendous amount of hope that can actually come from being a part of a community that definitely understands what stroke is all about, and I just don't think that there should be any limitations to anyone's ability to attend a support group or be a part of a community like a support group that deals with stroke. So before we get started and before we introduce our just fabulous featured guest that we're going to have here, I want to go around the table and introduce some of the members of our stroke support group that I've just had the pleasure of knowing over the past several months, and they're here, and so we're just going to kind of go around the horn so you guys can meet them and all that kind of stuff. So we're going to go around the horn and introduce everybody that's here.
My name is Gene. I had a ischemic stroke about 7 years ago, and I'm primarily on a mission to educate the public about my goals.
Mm-hmm. And Gene, let me ask you a question. What were some of the deficits that you immediately had when you had your stroke?
Primarily it had to do with communication.
Mm-hmm.
I'm unable to write or speak.
Mm-hmm.
And write that had a slight deficit, but with some practice you can overcome with that.
Right. So good.
My name's Gil. I had a hemorrhagic stroke about six and a half years ago, and I have left-sided hemiplegia. And I've been recovering pretty well so far. I'm doing a lot of things. I can drive, and fortunately, my speech wasn't affected very much, a little bit. But hopefully, I'll keep improving, and I walk with a cane now, and we'll see how that goes. Everything turns out.
You know, I got to say too about Gilbert, and I've said this to him before, is that when I attended one of the first support groups I ever went to, I still hadn't met anybody that had a hemorrhagic stroke. And, laying in the hospital and in rehab, for a month and a half, and I'm on Dr. Google and Dr. YouTube, searching hemorrhagic stroke and finding very little. I definitely had never met anybody that had a hemorrhagic stroke. I'd heard about all kinds of success stories and survival stories of people that had ischemic strokes, but no one that had a hemorrhagic stroke. And I'm thinking, oh my gosh, maybe they all died. Maybe they just, because, as I'm sure, our doctors know, is that hemorrhagic strokes are the worst kind of strokes. More people die of hemorrhagic strokes than they do of ischemic strokes. And so, that was a scary statistic for me to even hear. But then when I met Gilbert, and it was just like, wow, there's somebody that's like kind of like me, and like, wow, and I just got so much hope from him. And so plus he's just a really cool guy. My mom digs him. He's just a cool guy. So anyway, I'm just glad that he could be a part of this and all of that. So big shout out to you, man.
Thank you, Chris.
Absolutely.
Shall we pass it on?
Yeah, let's keep on going around the table.
I'm John, and I had my stroke 3 years ago, and it was a hemorrhagic stroke too.
Oh, I didn't know that, John.
And it was bad, bad. And I'm talking, and and driving now too.
Right.
But it was rough.
Right.
Rough stuff.
You know, and not that I was going to say I'm so fascinated by your story about how you had your stroke, which is, that you know what I mean. I don't mean it like that. I just really mean, and I really say this because the shout out to your son, Evan.
Yes.
Tell a little bit
Yes.
about that story. I love this story.
He is autistic, but he phoned 911 for me. And Evan is in Eagle Scout now. And it was him who called 911 for me.
You know, this crying warning number one for, you know, everybody that knows me, I'm a crier, and it's not because I have pseudo Bopar affect or anything like that. I'm just a really emotional person. But people that know me know that my background is in television, and I won an Emmy Award for a kids TV show called Hang On to the Dream, where we do stories on great kids that do great things, and then we ambush them and give them stuff. And we've put kids in college. We've done all kinds of really cool things and to help support kids. And I think that's what really blows me away about your story, man, is because, you know, especially when you hear about autism and things like that, and people just immediately just kind of, you know, write off kids that have autism and stuff like that. But yet, you know, look at your boy. Look at him, you know. He saved his dad. He's an Eagle Scout. I mean, he is proving exactly what everybody needs to understand, you know?
Yeah. Emily, Lawson, and Landon didn't do it.
Those are your other
Evan
kids?
did.
Mm-hmm.
Yeah.
Mm-hmm. Well, Evan just knew and picked up on it and just, that's why he's an Eagle Scout.
Yeah.
That's why he's a great young man. And I've sent word to him through you before, you know, just tell him we're all proud of him, man. We're just so proud of him. So we've come back around to the table here, and we're going to introduce our featured speaker and our featured guest, who I'm just really thrilled to be able to be acquainted with, Dr. Robert Darflinger. And he has a quite extensive background in medicine that I won't even begin to try to say. I'll let him describe his accomplishments and his achievements and why he's here.
Thank you, Chris. Rob Darflinger, I just want to say thanks again for allowing us to participate in this, and I want to say thanks for making my my eyes well up. But
okay, so I'm not the only one that was at the table crying. Good.
I'm really happy to be here and be
Glad
part
to
of
have
this.
you, man.
So thanks again, and I'm really impressed with what you guys are doing. We need more of these groups.
Absolutely.
So my background was I started medical training in Chicago, and then did a 5-year residency here in Los Angeles at Kaiser. And then a 3-year fellowship up at UCSF in neurointerventional. So I'm one of the neurointerventional surgeons that treat stroke over with the Pacific Neuroscience Institute and Providence Health. Basically, we're just the plumbers. We go in and take the clots out or treat the hemorrhagic strokes. And we can talk more about the different types of strokes, how they happen, why they happen.
And I guess your team, as you had emailed me yesterday, you guys treat some of the largest volume of stroke
That's correct.
patients.
We, with the Providence Health, we service 4 different hospitals. I have 3 partners, and we cover 4 different hospitals in the Los Angeles area.
Mm-hmm.
And with those hospitals, I think we treated a little over 250 ischemic strokes, not including the hemorrhagic strokes, this last year. So we have probably the highest volume in the Los Angeles area.
Wow. Well, you're gonna hear me say this many times. You know, I just thank you so much on behalf of all of us stroke survivors for what you've devoted your life to. You know, I mean, growing up, you could have said you wanted to be anything, you know, but you wanted to become a doctor. And you've now devoted your life to helping people like us get our lives back, and that just can't be just understated. I mean, that is just
Well,
so appreciative.
That's very nice. That's very gracious of you. We all just feel very lucky every day to be able to do what we do, and we feel very privileged to help people. And our patients put their lives in our hand, and I think that's a privilege that we all take very, very seriously. And we just love to be able to do what we do.
Right. And you brought someone with you who really has just also her own wonderful story. Introduce yourself to everybody who's listening.
My name is Yesenia, and I'm the administrative coordinator for the Neuro-IR doctors and the program. And I basically do everything and anything I can to support them and to help the patients get treated and get the services that they deserve and have a right to, and also try to help educate the family members and be there as a support for the family. And as I've learned being on the team, once you're our patient, you're going to be our patient for a very long time. And we keep an eye on you, and I take that to heart. And I understand the struggles that come with just getting medical services. I come from an emergency room background, and I've been there in the trenches and seen patients come in, and then the family members come in and they have no idea what's going on because there's a million things happening. But I always like to say that within at least where I come from in the admitting team in Providence, St. John's, and St. Joseph's, I always say, keep calm. There's nothing is under control, and we might as well just, do the best we can. So I know some people have that fight or flight feeling, and I'm grateful to be able to just stand there and be some sort of support for the family and try to explain it to them, because we've become so desensitized working in healthcare that we forget, that this is the worst day of somebody's life.
Sure.
And it's going to forever change. So having that background and having that, passion for myself and my work, I'm grateful to be part of this team and to put all of my knowledge and all of my experience to hand and have the support and try to give that support to the stroke survivors and the family members. So I'm grateful to be here, and this is something that we really are passionate about, trying to bring more awareness to the community, education, prevention. We're even putting our efforts into the Hispanic community, and we just want to put it out there as much as we can and just blast it out, because people need to know that there's support groups like this out there, and there's doctors like Rob and Dr. Tawari and Teitelbaum and Jason Tarpley and Dr. Sam Ho that are all over LA County driving around because they got a call that there's a patient in the ER and has a stroke, and they're going above and beyond, and there's no reason for me not to either. So.
Right. Well, as I said earlier to you, Yesenia, is that, you are so vital at one of the most crucial moments. You're kind of like the second responder, if you will. Obviously the first responder being the ambulance, but then you're the next face.
Yeah.
Once, someone like me is taken out of the ambulance, or once someone like my mom, comes rushing in, wondering what the heck is going on, they meet someone like you that, just kind of helps calm the waters and kind of breaks down, okay, this is what's going on right now. This is what's going to start to happen now. We're going to, take your son or daughter or husband or wife or whoever into the, to the room and, try to get understanding what's happening and get them into a CT scan or MRI or whatever. You're that calming voice that comes at such a crucial moment. And, it's interesting, and I'm going to kind of out you a little bit in the respect that one thing you left off is that your original introduction to all of this was in housekeeping.
Yes.
And, it's funny, I won't get into a whole religious thing here. I'm a little bit of a Jesus freak, and I ain't afraid to say it. So, but no harm, no foul to anyone that isn't. But I guess what I was going to say is, isn't it interesting how our lives are kind of dictated, and our path is just kind of guided to where we should be.
Yes.
And you were saying earlier before we went on the air about how you started out in housekeeping, and then you kind of you were thinking, what am I going to do? Maybe I want to go into the finance world and this, that, and the other, and somebody pulled you back and said, nope, you're coming with us.
That's exactly what happened. So I even told Rob and, our PAs, I was this close to moving. I was, selling my soul to the finance world and just, going into analytics and just forgetting about patient care, or just giving back. But something happened, and it just, brought me back, and I stumbled upon this position, and I'm grateful every day. So.
And as you were telling me earlier, you are right where you want to be now, and right where you need to be, and you ain't going anywhere.
Yeah, I'm not going anywhere.
Absolutely, and I don't think there's many people that probably would let you go.
No.
Dr. Darflinger is like, nope, she ain't going anywhere.
No.
That's all right. That's all right. Well, we're glad to have you here,
Thank you.
And I'm sure all the listeners will get a lot out of all of this that everybody's going to contribute during the show today. So, Doctor, I know this is going to sound, kind of very elementary, but, we're just going to kind of start from the very beginning and just give a thumbnail sketch of what the heck is stroke, and who, what, where, and why. How in the world did we get here?
That's a great question. So, stroke is a term that we use that encompasses a lot of different things, either hemorrhagic stroke or ischemic stroke being the two biggest. There's about 800,000 new strokes a year in the United States, about 130,000 deaths per year in the United States from stroke. It's now the number 5 leading cause of mortality in the United States. A few months ago, it was number 4, but I think we've gotten a little bit better at saving people recently. But it is the number 1 cause of major morbidity, meaning you don't necessarily die from it, but you're pretty disabled from these strokes. So it's the number 1 cause of major disability. I think we spend about $50 billion a year on stroke. In a general sense, stroke, we break it down into ischemic stroke and hemorrhagic stroke. Ischemic stroke is about 85% of the strokes that we have, and hemorrhagic is about 15%. The ischemic stroke kind of falls into a couple different categories as well. Either you have a blood vessel that supplies the brain that closed down spontaneously, or you have a clot somewhere else in the body that gets up and ends up occluding one of the blood vessels to the brain. And those are the 2 primary causes for ischemic stroke. Hemorrhagic stroke, there's several different causes for those. Probably the 2 most common would be a high blood pressure can cause hemorrhagic stroke, hypertension, or aneurysms and some other vascular abnormalities that can cause a hemorrhagic stroke. And those are the 2 big broad categories that we use for stroke.
Mm-hmm. Sometimes I hear about AVMs being considered a stroke, but not.
That's right. AVM, arteriovenous malformation, is what AVM stands for. That is one of the types of hemorrhagic stroke. It's not one of the most common, but again, we kind of, in the general sense, when we're talking to people on the street, we use the term stroke. For people like me, we obviously differentiate those into the more specific categories. But yeah, arteriovenous malformation is a cause for a hemorrhagic stroke. That kind of, we put that into the neurovascular disease, which is kind of what I do. Like I said, I'm a plumber, so we look at all the blood vessels and the various pathologies that can happen with those.
Mm-hmm. Now, as you've heard me say before, we were talking earlier, I always thought strokes happened to the little old lady down the street. I did not think it happened to a young guy like me who's, walking 2 miles a day, riding show horses all around the world,
Absolutely.
Hosting a TV show and everything else. And, like, what the heck just happened here? But then through now being part of this community, I'm starting to understand that stroke is actually happening younger and younger. And seeing younger faces at some of these support groups and things like that. Talk a little bit about that.
Yeah, it does. You're absolutely right. So when we look at the risk factors for stroke, all causes stroke, hemorrhagic or ischemic, age is one of those risk factors. And in general, in the literature, we say, at 50 years old is when the risk of stroke becomes more prevalent. But that's only the most common. Certainly, we've seen patients that are younger than that. You're right. You're very young. You're very healthy. We definitely see patients that have strokes at a younger age. I'm looking around, and everybody here is fairly young, but strokes can still happen. And one of the things and the reason that Yesenia and I have been so passionate about this, you mentioned that your son recognized these symptoms and called. My eyes were kind of welling up from this, but your son was the one that recognized these symptoms.
Yes. He is an Eagle Scout now, but Evan noticed it first and got me to the doctors. Mm-hmm. Yeah.
So, one of the reasons that Yesenia and I have been so passionate about doing some outreach is that we haven't been as good as a community at teaching people to recognize these things, right? So we in medicine have been exceptionally well with heart attacks and getting that information out. And over the last, decade to 15 years, we've gotten so good at treating people very early on that are having heart attacks because we were able to get out there and teach people to look for the symptoms. We haven't been that good with stroke. Mm-hmm. And one of the things that we've been doing is going to some of the fire departments and going to the high schools and teaching people, and even the younger people. It's very important, for the kids to understand what the symptoms are, because the person that's having the stroke isn't going to help themselves.
Sure.
So we're trying to get out there and really teach the community about recognizing the symptoms, what to do for a stroke, how important time is for these things, because time is absolutely everything. Mm-hmm. One statistic that we throw around at all of our conferences, 1.2 million neurons die every minute while somebody is having a stroke. So time is really the most important thing, and we need to get better at teaching the community to recognize their family members, their friends, their coworkers when something is happening, so that they can get there. And I'm just so happy to hear that your son. That's just a phenomenal story.
Yes, and Huntington Hospital was close by, and it was good for me to do it.
One of the things that you were talking about time too, and one of the reasons why I want to do a show like this and host this support group that we do on Thursdays, is that through going to these support groups, I've learned so much about the amount of recovery that can happen over time. While I was in the hospital and things like that, one of the things that stuck out is, when I was in intensive care, there's constantly doctors coming in and out and in and out. And one of the things, there was one doctor that came in, I've never forgotten what she said. She goes, don't worry, because understand that the body is designed to heal itself. That's why when we cut ourselves, we grow a scab. When we break a bone, you put a cast on. 6 weeks later, your bone is healed. It's just that the brain heals a little slower, but that the body does heal itself. Well, and that was really great. And then I started to hear the statistic of, or not the statistic, but the quote of time being, well, a lot of neuroplasticity comes back within 3 months, and in 6 months it starts to, kind of plateau a little bit, and then after a year, that's pretty much your new normal. You're not going to get much more after that. And, here I am 7 months in, I'm like, oh my gosh, I'm looking at the clock, and, and when I hit the 3 month period, I was ready to have another stroke. I mean, not physically, but just mentally. I was like, oh my gosh, it's 3 months, and I'm still walking like a mess, and my arm isn't working, and oh my gosh, I got to, come on, man, I got to get this going. But through going to these support groups, and again, this is why I'm doing this show, is that I meet people like John and other people who, I hear these stories of how, hey, after a year, I didn't have anything, but now I'm dancing a jig, I'm playing the violin, and I'm 3 years out of the stroke. So you start to learn that it's not exactly as you were told so much, that 1 year isn't so much the marker of things. Even John shaking his head now, that, John, I guess there was a point where you weren't speaking for a long time.
Yes, and now I'm speaking a lot. But it's getting better for me, but it's hard, but it's getting...
It's progressive.
More, yeah.
Right.
And I write now and communicate and text well and stuff. And
these are all things that happened after that 1 year period.
Yes.
Right, because your stroke, you said, was almost 3 years ago. You were
Yes,
telling us
it
earlier.
is.
So for everybody listening, if you're like me and you're new into this stroke thing, or if you've been in it for a long time, understand, and doctor, you can certainly correct me if I'm wrong, recovery doesn't stop at that.
That's correct. And you mentioned in medicine, unfortunately, we do go by a lot of metrics, and we go by a lot of literature as best as we know it, and we don't always know the answer. And so people do use this 6 month and 1 year, and I completely 100% agree. That does not mean that's not the end of that's the end of recovery. I have seen many patients follow up with me in clinic who continue to get better after that time. And I think ultimately where we're going with stroke treatment, the next big paradigm is what do we do for recovery and how do we improve the recovery process. Back in 2015, we had 5 major articles in New England Journal of Medicine that showed why we should treat stroke and how we should treat stroke best, and that's become the standard of care. What we're doing now and what we're able to do is phenomenal, but the next step is, well, what do we do after we've treated the stroke? What do we do to facilitate the recovery? And a lot of the money and research now is going into that. And I think that's where we're going to see the next big step with stroke treatment.
I remember one of the other questions I had when I was in rehab. I was at a rehabilitation hospital for about a month and a half, a little over a month. And I remember asking one of the therapists, well, what's this? What am I going to be like 6 months from now, or a year from now, or something like that? And they said, well, and to their defense, they really couldn't answer it per se. And they told me because it's not because they don't know, as a person they don't know. It's just that they don't get to see many of their patients beyond a certain length of time. Like once insurance cuts the patient off, they don't see them anymore. Maybe they'll come back and visit at Christmas time and bring cookies or a present or something, but they don't get to see what some of their patients look like post-stroke 2 years, 3 years down the line, and see how much more they've improved since they saw them post-stroke of like a month or a few weeks. They see us very early on. They don't see us much later on, so they don't really have anything to compare
That's right.
it to.
That's absolutely right. And we have numbers that we look for, and a lot of places in the country don't have the capability of following patients post, after 90 days. That's usually when patients start to kind of drift off. We're dropping the ball on the recovery. After a stroke, somebody may get inpatient rehabilitation or acute rehab for a short period of time, a couple weeks. And then, oftentimes they're going to some nursing facility, which can vary on the quality or the amount of time that they can give to some individual post-stroke. This is somewhere where in medicine we're dropping the ball, and I think this is where the next step is really going to improve over the next few years. At least I'm hopeful.
Right.
And I think it's going to take a lot more of us with these groups getting out there and saying, well, look, we need to have insurance coverage for this. This is going to be better for everybody. We need to have a more robust recovery plan and strategy and more research, and what can we do to improve that.
Well, and again, that's why, I'm very passionate about having these kind of support groups that I'm having here, is because, I want everybody that's listening to understand that, I have met so many people who have told me how much more they've progressed well outside of that little guideline, and well outside of, that fearful 3-month period, and that fearful 6-month plateau, and that fearful 1-year new normal, and things like that. So, that's again the reason why this support group is here, and this radio version of it is here, is so that people who don't have access to something like this in their community can at least live through some of these people here. I know Yesenia wants to say something, and then Gilbert, we go to you. Yep.
I just wanted to add that it does take a team for the aftercare, and I tell that a lot to the family members and the patients, because I deal with that insurance barriers, and it's really hard to get that consistent treatment, which we need, obviously, just to have it be consistent and with the right provider that know your history. And insurance, as much as we us in medicine don't want to get into politics, it is political, and we need to do something more proactive towards that. But right now, I think the best we can do, and we can keep pushing and get to that point, is by educating and letting the people know their rights and what they can do to maneuver themselves around the insurance barriers, because that's the hardest thing, to get to that physical therapy. And once they look at that referral, and once they get it approved, and once they call you, like I know how it is. So just keep pushing, and it does take patience, but just continue to have that hope that there are people out there going to help and willing to help. And that's why I love Pacific Neuroscience Institute, and having all the neuroscience disciplines in that group, because it's a team, it's an interdisciplinary team, and it's a care. So if you guys fall into our hands, we have other doctors that we consult with, and we want to keep it within the same group and consistent, because that's what patients need. And it's hard, but we're working really hard towards that, to remove those barriers. But it definitely it's going to take some time. That's
so encouraging to know that there's people that are fighting for that. Gilbert, you had a question?
Well, I want to get back to recognizing stroke.
Yes, sir.
And I think there's some misinformation out there. Back in the day, it was if you recognize someone having a stroke, they would say give them an aspirin, and I think that could be fatal. If you have a hemorrhagic stroke and you give someone an aspirin, that would cause more.
Absolutely.
So can you please tell us about recognizing strokes and what to do and what not to do?
Yes, sir. Absolutely. So again, kind of to get an overall picture, there's kind of 3 major areas that I look at stroke when I'm trying to work with the community. It's recognizing the stroke and what to do for a stroke, the treatment of a stroke, and then the post-stroke care. We've really sorted out the treatment of stroke now, and our ability to go in and either take clots out of the blood vessels or treat an aneurysm or an arteriovenous malformation is really just getting better and better all the time. What you're asking about is recognizing the stroke, what to do when you have a family member or a friend. So there's a couple different things that we're trying to get out to the community to teach them. And as I mentioned before, we've been really good at this with cardiac arrest and heart attack. And one of the reasons is you can't ignore this crushing chest pain that puts you down on the ground. Whereas a stroke can be ignored because somebody may have very subtle symptoms, slurred speech, a dizziness, or an imbalance. And people don't like going to doctors. I don't even like going to doctors. I don't want to be at the hospital any more than I have to. So I completely understand when somebody else doesn't want to go to the hospital. And so people will ignore by nature very small things and say, you know, maybe it'll get better. It'll be okay. And that's one of the reasons that stroke is a little bit harder to treat, because patients sometimes ignore those symptoms. Family doesn't recognize the symptoms. There's a couple different acronyms that we're using to try and get out into the community. BEFAST, BEFAST. And each one of those letters is supposed to represent one of the symptoms. So B, for example, is balance or a sudden loss of balance. The E would represent your eyes. Oftentimes when you have a stroke, your eyes are going to deviate to one side or the other. You'll start looking in one direction. We say you look at the stroke as a physician. But you also could lose vision, even if it's a small amount of your vision. That's not something to ignore. Your face, that's what the F stands for. You usually have one side of your face and I'm sure you guys know this better than I do. You can have one side of your face, the motor isn't working as well as it used to. And that would also manifest as slurred speech. If one side of your mouth isn't working, you're going to have slurred speech. A is for arms. If one arm is weaker than the other, that's a very, very strong symptom that somebody needs to get to the hospital immediately. S is for speech. We kind of mentioned that a little bit. Slurred speech or trouble, either we call it aphasia, and it comes in a couple different flavors. One is an aphasia, we would call it receptive aphasia, meaning you're not able to receive the information that is coming in. You can't understand what people are saying to you. The other is an expressive aphasia, and I've seen it many times with patients where I'm talking to them. It's very clear to me that they understand what I'm saying, so they're receiving the information okay, but they can't express it. They can't talk and they can't speak. That's what we call expressive aphasia, and I would put that into the speech. And then the last part of the BFAST, the T, is really just to remind people that time is the most important factor in that. So this is one of the things that we're trying to get out to the community, to recognize these symptoms. One of the other problems is, aside from a stroke, there's another condition called a transient ischemic attack, a TIA, exactly. And the real problem with the TIA is these are symptoms of a stroke that by definition resolve within 24 hours, and the vast majority of them actually resolve much earlier than that, within the first hour or two. And the problem there is that when somebody has these symptoms, because they don't want to go to a doctor, as soon as the symptoms resolve, they decide not to go to the doctor. And the very big concern for that is that 5% of those people with TIAs are going to have a stroke within the next 48 hours. And 10.5% are going to have a stroke within the next 3 months. So one of the other things that we're trying to teach people in the community about is, hey, look, you've had this problem. It seems to have resolved. You got to get looked at. You had extremely high risk of having a stroke in the next 3 months.
And doctor, you could not be more correct, at least certainly from my own personal experience. I pretty much know for 100% fact that I did have a TIA about 10 days before I had my stroke. I was actually giving somebody a riding lesson, a horseback riding lesson. For people that know me know that I ride horses. For people that don't know me, I am a competitive horseback rider. I show horses all around the world. And I was teaching somebody how to, giving somebody a riding lesson. And while I was speaking, which I've done tens of thousands of times, I've given clinics in riding all around the world. But while I was teaching this person, I remember my speech was starting to slur, and I wasn't confused, but I remember thinking, why is my speech slurring right now? Because we talk to the rider as they're riding, and my speech started to get so slurred, not super noticeably, but enough to where I knew it, and now maybe they didn't know it. But I remember thinking, okay, this is really hard for me to talk right now. Why is this happening? And I thought, well, maybe my blood pressure just got high, but I did take my medicine this morning, so I don't know. And within maybe 15 minutes, it went away. Like not a sign of anything. And I didn't think any more of it. I just thought, you know what? Who knows what that was about? Well, 10 days later, I found out what it probably was about. So what you're saying there is very correct. And to go back to Gilbert, first of all, this guy is just the coolest guy in the world. Like I said, he was one of the first people I met when I was trying to find somebody, not really find somebody that had a hemorrhagic stroke, but somebody I could just look to for any kind of guidance or any kind of information, because I'm only 3 months in at this point and I don't know what the heck's going on. But Gilbert raises a very, very important point, and I preach about it constantly, is that when I was in the back of the ambulance getting taken to the hospital, I was at my television studio, and the ambulance took me to the first hospital that was nearby, which you would think would be the thing to do. Well, the dispatcher said, oh, if he's a stroke patient, don't take him there. You have to take him to a comprehensive stroke unit hospital, which is another hospital way on the other side of town. And so I'm in the back thinking, come on, man, get me there, because I got to get that drug that I hear about that, you give to stroke patients that, reverses stuff. If I'd have gotten that drug, I'd have been dead. Because
That's right, yeah.
I was having hemorrhagic stroke. And so this is why, again, I'm so passionate about having a show like this for people like you guys to come on and tell people, to us lay people and people who don't know this ahead of time, that it's great that there is that drug, but that drug's not meant for everybody, that there are different kinds of strokes. And
That's correct.
To get that drug that could be very helpful for one could be completely tragic for another.
That's right. You're the drug that you're talking about, and I'm sorry, I don't think I answered the aspirin question completely. Aspirin is an antiplatelet. It's the goal is we do that immediately for cardiac arrest because that's always a closure of the vessel, and 85% of the strokes that we have are ischemic, and aspirin would help those. That 15% where it's a hemorrhagic stroke, that's not what you want to do. That's very counterproductive. And so the best treatment, if you're asking, should people give aspirin to people with stroke, I would say no, they just need to get to one of these hospitals. And you mentioned the different types of hospitals. That's because at these hospitals that are comprehensive stroke centers, they have people like me who can go in and pull the clot out or treat the aneurysm. We're very fortunate in Los Angeles that there are a lot of these hospitals, so it's not too far wherever you're at in the city to get to somebody. And I know all the other interventionalists in this area. They're fantastic hospitals and fantastic interventionalists all over the city. So we're very fortunate here. Some other places, rural areas, it's a lot harder to get there. But anybody who recognizes one of these symptoms and their family members, just get them to one of these hospitals. Get them to any hospital as fast as you can, and they'll know where to send the patients. And you're right, the medication that you were talking about, Alteplase, it's a TPA, which is a medication that we use to break up clots in the brain. And that's a good medication. We're very fortunate to have that for ischemic stroke. That's not going to usually solve the problem, but it's not something you want to give to somebody that's bleeding. That's correct.
Right. Well, we've got so much more information to cover, and I know there's more questions here. We're going to take a break, and we'll be right back. Hey everybody, welcome back to the show. This is Life After Stroke. I'm Christopher Ewing, and we're basically here doing what we normally do. We have a support group that we actually put on the radio. So it's kind of a little mixture, a little surf and turf here, a support group mixed with a radio show. And we've got an excellent guest here with us today. His name is Dr. Robert Darflinger. He has an extensive history in treating stroke, and is just an all-around awesome guy, and I'm so blessed to be able to have met him. And we've got some more questions here at the table.
The doctor mentioned time, and time is something that's quantifiable. So let's start there. I'll quickly give the microphone to Gil.
No, we give the microphone to Gilbert. He's like afraid to ask the question. So your question is about time.
Time, right? So time with stroke is the most important factor. As I kind of mentioned earlier, every minute 1.2 million neurons die when you're having an ischemic stroke. So what happens when somebody's having a stroke? There's a couple different treatments that are available for them. We're just talking about ischemic stroke for now, not hemorrhagic stroke. Ischemic stroke, we have to determine really when that onset was, and that's going to determine what treatments are available. So there's a medication that we give. We briefly talked about Alteplase, or TPA. That's a medication that helps break up clots. That can be given generally within 3 hours of a stroke, and in some patient populations that is extended to 4.5 hours. There's some studies now on some variations of that medication that is looking on extended treatment or treatment outside of that 4.5 windows. We're trying to participate in some of these studies, and a lot of people in the country are trying to look at how long out from a stroke we can give that medication. That medication is very good. It used to be the standard. But recently in 2015, 5 big trials came out that compared that medication to an actual surgery that we do to pull the clot out. Overwhelmingly, all of these studies were stopped because the treatment, the actual surgery is better.
Was this drug like a clot buster? Was
It is.
It's like Drano kind of thing or something?
It is. It's like I said, we're plumbers, so it's kind of the Drano before we get in there. That's what people give before we go in with our pipes.
So it just dissolves whatever that clot was.
It's called Alteplase, is the main drug. Tissue plasminogen activator is what we use, and that it's a precursor to a protein that helps break up the clots that occur in our body from the platelets aggregating to each other and forming fibrin clots. So this is a precursor to something that occurs naturally in our body that helps break up the clots. It's a great drug. It does help, particularly for smaller clots further out into the blood vessels, but the studies have overwhelmingly shown that when you have a very large vessel occlusion, meaning your internal carotid or the first branches, the bigger 5 millimeter branches with a clot there, that the medication alone isn't going to do the trick. And so what we end up having to do then is to pull the clot out using a couple different devices. Usually we put a tube into the artery in the leg, or we can find some other arteries if we need to. But the long and short of it is we feed a series of tubes through the blood vessels in the neck up into the brain. And then there's a couple different devices that we use there to either latch on and grab the clot or to suck the clot out of the blood vessel in the head or neck. And that's called mechanical or aspiration thrombectomy.
And how long does that procedure take?
It's a great question. So up until just in the last year, we were doing that treatment compulsory up to 6 hours.
So it takes 6 hours to do that?
Oh no, the procedure itself, we do it as fast as we can, and we can get those done. In a good case, we can get those done less than a half an hour.
So you can find the clot in less than a half an hour.
Oh yeah, we can find the clot immediately.
But now this window of time, was it 6 hours? You were saying it's the best to do it?
That's the mainstay. What used to be the mainstay, we would do these thrombectomies up to 6 hours, and that's based on these large 5 trials that were published, in 2015 that showed that you have a 60 to 80% chance of a better functional outcome by us going and pulling the clot out. There were a couple, and these were phenomenal trials. The data that we have for treating stroke and pulling clots out of people's head is amongst the best data that we have in all of medicine. This is by far the standard of care. There really isn't much that we do in medicine that has as much evidence for doing this. But we didn't know at that time how far out we can treat a patient from when they were last seen normal. Okay, meaning when was the last time somebody actually saw that person acting normally? And that's the metric that we use for treatment. There were some patients, so most of those trials included doing a thrombectomy, doing the surgery on people up to 6 hours. There were some of those trials included patients that were outside of that 6 hours, meaning they were seen, maybe 12 hours, or they woke up. Very common, we call it a wake-up stroke. Somebody that wakes up in the morning or in the middle of the night. We don't know when they actually had the stroke. And there were some of these trials that included those patients, and they actually benefited from having the thrombectomy, having the surgery as well. The number of patients that were included in those trials outside of the 6 hour windows wasn't enough for us to make a determination on, but it was enough for us to do more studies. And so we recently had 2 studies that looked at either up to 18 hours or up to 24 hours. These are the Dawn and Diffuse trials. And we evaluated patients in the extended window that we would do a thrombectomy on. And based on a little bit of additional criteria that we used through our CAT scan and evaluating the patient's symptoms, we now treat patients up to 24 hours in certain circumstances. And both of these trials, again, were also stopped early because the treatment group benefited so much better from the treatment than not having the treatment that the trials had to be stopped early.
And then when you feed this kind of roto-rooter thing up into the brain to find this clot, is there a camera on the end of this thing, or how do you find it?
That's a very good question. The way it works is we have usually most of us have 2 cameras. It's an X-ray. We call them cameras, but it's an X-ray. From the outside. From the outside. So when we put the tubes into the arteries and we get the tubes into the arteries in the neck that supply the blood vessels of the brain, we inject a contrast or a dye. It's an iodine-based dye. We inject that into that blood vessel, and that fills up all the blood vessels of the head. We then take X-rays, live X-rays, as that dye goes through the blood vessels of the head. and the dye is able to show up on the x-ray. So we get a full map of all the blood vessels of the head using the x-rays, and we can see where the clot is in the blood vessel because the dye won't go
Don't
past
go
the clot.
past there.
And so then we use that to direct smaller, very, very tiny tubes past the clot or up to the clot to be able to grab it.
And then you can follow the tube also visually.
Yeah, the tubes you can see on X-ray. So it's all being done on X-ray. So there's
all
no
in live time. I see.
all live. Yeah.
Gotcha. Now, the thing that I, learned through the hemorrhagic stroke is that blood and brain don't mix.
right.
It's
That's
kind of
right.
like, and I've kind of, and correct me if I'm not explaining this correctly, but I've kind of described it as to how it was kind of told to me. The best way I can describe it is that it's like if you spilt coffee on a piece of paper, and everywhere that coffee is now going to and traveling, it's ruining the surface of that paper or that surface
right.
of that table type of thing. You want blood in your brain, but you don't want it on your brain. Is that basically kind
That's
of...
right. So, the blood vessels, when they get up to the head, it's a series of divisions of that blood vessel from the artery side into what we call the capillary bed, where the gases and the nutrients are exchanged within the tissue. And a lot of people don't realize this. The brain is actually very, very, very soft. Even medical students like myself who do, anatomy, that's all been treated with different chemicals. So the brain that we touch is harder on an anatomy specimen than it is in the brain. It's extremely soft tissue. And when you have a hemorrhagic stroke, let's say a hypertensive stroke, what you have there is the wall of one of the blood vessels has ruptured, and now you have blood coming out there, at approximately 150 to 200, if it's a hypertensive stroke, 200 millimeters of mercury of pressure. It just dissects into the parenchyma, into the tissue of the brain, and injures it.
And everywhere that the blood touches, it kills that part of the brain or destroys it.
More or less, yeah.
Disturbs
It dissects through that tissue and completely ruptures that tissue, which now isn't getting any oxygen anyway as well, right? Or
Because it
any
was
gas
described to me that everywhere the blood touches, it's kind of destroying that part of the brain, of
Correct,
the area,
yeah.
because it's
that's
toxic to the brain, is what I was told.
The brain doesn't want the blood on the outside of the tissue. It wants
Correct.
it at the
in the inside.
Yeah.
Right. And what happened with me is my brain, it swelled.
Right.
But I didn't need surgery, and they didn't have to, cut. But I remember seeing patients in the hospital who did have to have, I don't know how else to say it, had kind of have the top of their head taken off a little bit
Correct,
to
yeah.
allow for the expansion of their brain and the swelling.
That's correct. The biggest, it's the swelling of the brain or edema. It's really not that much different than if you have swelling on your hand. If you hurt your hand or if you break a bone, you're going to have edema and swelling. That's part of the inflammatory process. The problem with the brain is there's nowhere for it to swell. And so once the brain really starts to swell up, it compresses the rest of the brain structures, and that can be catastrophic. So in some cases we do have to do surgeries to release some of that pressure and allow the expansion.
And now with somebody who has a hemorrhagic stroke, and let's say they're excessively bleeding, like I think they did a series of CAT scans on me to kind of find out where the bleeding was at this point. Like from what I remember, like as soon as I got there, they did something, and then they waited a few hours
That's
for
right.
another one,
Yeah,
and
that's
then
right.
they did another test to see if it was still bleeding or if it stopped or whatever. If it continues to bleed, what do you do then? Do you kind of put like a little gutter in there and try to run some of the blood off, or?
So that's a good question. So in a hypertensive hemorrhage, usually once they get to the hospital, those don't tend to bleed a great deal more, right? We get the imaging to make sure that there's stability and see how the swelling is and to see how much mass effect there is from that hematoma, that big bleed in the brain. Typically, they don't continue to bleed because, of course, by then we've gotten the blood pressure under control. People who do continue to bleed in the brain usually don't make it to the hospital. And if we were talking about, for example, a different type of hemorrhagic stroke, an aneurysmal stroke, where you've had it's a weakness in the wall of the blood vessel that kind of balloons out, looks like a little pouch, that's what we call a subarachnoid hemorrhage, and it's different than a hypertensive hemorrhage. So
What's the difference?
So a high blood pressure hemorrhage occurs in the smaller vessels that perforate into the tissue of the brain. and it's very classic in certain areas. Basal ganglia, which I think is what you mentioned,
that's what I had.
lobar, the frontal lobes, those are kind of the classic areas. And those are, because the blood pressure is so high, there's a rupture just in the sidewall of a blood vessel that's perforating into the substance. Okay, so that's actually within the tissue of the brain. An aneurysm is a weakness in the wall of the blood vessel, which the blood vessels course on the surface of the brain. So when that ruptures, it doesn't typically, not always, but doesn't typically bleed into the substance of the brain. It releases all of the blood around the surface of the brain in what we call the subarachnoid space, which is one of the areas around the brain. Those 1/3 of the people with aneurysms that bleed, they're just numbers that we use in general, about 1/3 of the people that have a ruptured aneurysm never survive to make it to the hospital. About 1/3 will make it to the hospital but continue to have deficits, and about 1/3 will recover completely. These are just general numbers that are used. But for that, if somebody has a ruptured aneurysm, the symptoms of that are typically very, very different than an ischemic stroke. Those symptoms would be, classically, we call it the worst headache of your life. I mean, this is a headache you've never had before.
Which one?
The subarachnoid hemorrhage, a ruptured aneurysm. This is the worst headache you've ever had in your life, and that's because the blood on the outside of the brain, along the lining of both the brain and the skull, it's very irritating. It's extremely painful. This is something that puts you down on your knees because it's so painful. Anybody with those symptoms needs to come in right away. The people who are able to make it to the hospital are those where we believe your body makes a temporary closure of the ruptured aneurysm. We all clot when we have a cut. We think that these are the people that have clotted off that area where the aneurysm ruptured, but that's a very weak closure, and those aneurysms do need to be treated. They're extremely high risk for bleeding again.
Yeah, and that's, gosh, you're bringing back all kinds of weird memories now, because I remember them saying that mine was within the center of my brain, so they couldn't really get in there and do anything because they have to drill into my brain to do it.
Yeah, the studies have not been very good on going out for these.
And then, as it all works out, I hold a big award show every year out here in Hollywood. And wouldn't you know that this all happened that exact weekend? So I had hundreds of people that had flown in from all around the world to attend my event, and I'm supposed to be there. I'm the big host with the most, and blah, blah, blah. And, I'm not even there. I'm literally listening to my award show over the phone in intensive care. But I remember saying to the doctors, hey, look, I got like hundreds of people that just flew in for my annual awards. It's like our 7th year. And this is like old home weekend, can't I still go to my awards and at least just sit there? Because, these are all my friends. They all want to see me. I want to see them. And the doctor was like, okay, dude, look, man, you just had a stroke, okay? Let's just keep it real here. But then he was like, you know what?
That's a good sign, by the way. When patients are ready to leave right away, that's it's a good prognostic sign.
I'm ready to go.
Yeah.
It's like I don't have time for a stroke. I don't have time for this. Hence probably why I had a stroke, because I'm so busy all the time. But I remember, saying, well, can't I just go? Even if I promise I won't even lift a cable, I won't do anything. I'll just sit there, And he said, look, okay, you just had a brain bleed. You don't want it to open back up. We can't keep you here. I can go out to the other room and get the piece of paper and have you sign it, and you can be in the Uber in 2 seconds if you want. But I would suggest you not, because we're only at like a few hours into this right now. So my point is that you were saying that it closes very delicately.
Correct.
In the center. So I really could have screwed myself up had I gotten up and just decided I was going.
Absolutely. Absolutely. Yeah.
Crazy. So we're going to take another break, and then we're going to come back, and we've got more questions for you and all that kind of stuff. And there you go. So we'll be right back, everybody. Hey, everybody, we are back. And, during the break, Gilbert said something that was really kind of deep and really wild. What was that, man?
I just want to mention that when I had my hemorrhagic stroke, the bleeding continued for 4 days, and they told me that if it didn't stop after 4 days, they would have to go and do something, or try to go in and stop it or something. I don't know what they were going to do, or if they even could. But so I'm just wanted to let people know that you can survive a lot of things.
Right.
So.
Right.
That's right. We are surprisingly resilient. That it was bleeding for 4 days. What I'm imagining, just being one of the physicians that treat this, is either the edema, the swelling around that continued to increase. Usually people can't bleed for 4 days. they just don't survive. So we do see rebleeds with high blood pressure. You have injured tissue there. Once you've had the initial injury, that does cause necrosis or death of some of the tissue around it, and maybe it bled back into itself. We see that pretty regularly, but predominantly within the first 5 days, once you have that injury, your tissue starts to swell, you get edema. That occurs, the maximum amount of edema tends to occur about 3 to 5 days after the initial injury, and that's when the swelling is usually the worst. And it's interesting for us when we treat the stroke patients. Again, I feel so privileged and blessed to be able to do what I do. Patients come in, they get onto my table, they can't move their entire left side of their body. We put some tubes up there, we do some plumbing, we pull out some clots, and oftentimes before I can even pull the tubes out, they're moving again completely. It's just absolutely amazing to see. But there is usually some injury that takes place there, and as they leave the table and go back up to the intensive care unit where we have our stroke patients go, some of that swelling does manifest as a little bit of worsening over the next day or two. It's a little bit scary for us because we think everything is going great, and then they have some swelling. Maybe that's what was going on, some edema and causing some shift of your brain from one side.
The doctor said my brain was shifting to one side or the other, which would cause damage if they didn't stop the bleeding.
Absolutely.
So, it did stop on the 4th day, so unfortunately.
And again, that's kind of up to 5 days. That's usually 3 to 5 days is the peak of the swelling. So we do see that, and that's why we're getting multiple images. And I think somebody actually was asking me during the break earlier, what's the timeline? What do people expect? What should families expect when they have these strokes? Well, the first thing to do is to call 911, get your family member or whoever you're with to the hospital. The first things that we're going to do there are get the CAT scans, which is a type of X-ray. And that's going to tell us whether it's a hemorrhagic stroke or an ischemic stroke. From there, we're going to either, if it's an ischemic, if it's not hemorrhagic, we're going to do another type of CAT scan to look at the blood vessels to see if there's an occluded vessel. If there's an occluded vessel, we're going to get you onto the table and pull that clot out. That's the kind of overall big picture of what would happen. That whole process usually, we're getting faster and faster, and everybody's goal around the country who does this treatment is to move as fast as we can.
Is that the door to needle time that they talk about?
That's very good. Yeah, we use we use a lot of different metrics. We have door to CAT scan, CAT scan to angiosuite to needle, door to reperfusion, meaning when we've gotten that clot out and all the blood, we measure every single time factor on this. And every single minute counts. So what most of us in my field are doing are, now that we know the best treatment overall, all of us are trying to refine, how can we be faster at this? How can we be better at this? What can we improve at each step of this process?
You talked about how the area where the stroke happened, especially in the hemorrhagic situation, or even in the ischemic one, that area where the stroke took place, I guess, as you would say. What are the chances of that area, now that it's somewhat weakened, opening back up again days, weeks, months, years later? Is that kind of a weak site now, or is
where the stroke actually happened?
Yeah.
No. So when you actually have infarcted or stroke tissue, that tissue does not recover. You had mentioned neuroplasticity.
Now, is that a weakened point now?
It's the tissue. Once you've had the actual stroke, any tissue that has been without the oxygen for a certain period of time is going to die.
Okay.
And that doesn't come back.
Could that be a site where a stroke could happen again now that it's weakened? And,
okay. That's a great question. What happens in the immediate aftermath of the tissue having had a stroke is that it is dead tissue. It does not come back, but what can happen in that area is that it will bleed into itself, and we call that a hemorrhagic conversion. It's converted now to a hemorrhagic infarct. So you have ischemic tissue that's not getting oxygen, the tissue dies. Within the next few days to a week, there's the potential for that to bleed into itself, which is going to be worse than if it were just dead tissue.
So it's like a scab opening back up again.
Exactly. Or you bent, yeah, exactly. That's exactly right.
Now, will that forever be a weak point?
It will not forever be at a risk for bleeding into itself, but that tissue will become, over time, a kind of a cavity within the brain. And you have, all of this kind of support cells, your neuron is where all the activity takes place that helps us to control our body and to talk and to receive and express information. There's a lot of cells that are in the brain that aren't neurons that support the neurons and supply them with what they need to and remove debris and help the neurons heal. Over time, we call it gliosis. There's other cells, glial cells there, which are kind of support cells that will start to line that cavity. So it's no longer at a risk of bleeding or becoming further injured from that particular injury. It's essentially a scar that happens within that cavity of the tissue that has already died. Does that answer your
absolutely.
question? Yeah.
Absolutely. This is great. You know what? We're going to take one last break, and then we're going to come back and get your final thoughts and all that kind of stuff. Everybody sit tight. We'll be right back. If you have a question you'd like to ask on the air to one of the medical experts heard on the show, you can call the show's studio line at 213-297-8300. That's 213-297-8300. Or you can email your question by sending it to mail@lifeafterstrokeradio.com. mail@lifeafterstrokeradio.com. Hey everybody, welcome back to Life After Stroke. I'm Christopher Ewing, and Gene's got a question.
Yeah. My question is, would education of the lay public help?
Yes, absolutely. I was just saying that I'm really impressed at how educated you all are about what a comprehensive stroke center is, about just, the TIAs, what an AVM is, and it's a comparison to see when patients are following up at the clinic, and they're just completely unaware of what's going to happen next or what even happened to them because everything happens so fast. So yeah, education is very important, and I'm really trying to work hard on bringing some more information to just the patients itself, but now to the community in a vast scale where
there are two aspects of education. One is medical, and the other is what we call third parties.
Yes, absolutely. And I think a lot of this education needs to be taken on by the health insurances that really are providing these coverages that, they're just getting these premiums and they're not really providing much care. They should at least be giving out education to the patients of what their coverages are and what they can do. And I even make the call of just, making the recognition that strokes are happening more often, or we're seeing them more often, and we need to build we need to change the plans somehow so we can better accommodate patients, from within all the way out, just all the way out to the aspect.
Yesenia, that's why you are so important to be a part of this, because again, you're kind of the second responder, if you will. You're kind of that person that the family, when they first rush in, you're the first person that they come across who kind of, helps them calm everything down and kind of helps clear the smoke. And I'm sure you're just a wealth of information as to what families can do now that they find themselves in this situation, in terms of how to navigate through some of the bureaucracy and the red tape and paperwork and insurance and stuff like that.
I did it through university. I worked the system, and now I'm applying it to the healthcare system. And that's what I say to patients: you got to learn and you got to educate yourself, and you have a right to everything that you're you're paying for this, or even if you're on Medi-Cal, you have a right to know what is out there, even if it's not going to be with us or one of our doctors. You have a right to know where you get your services. So
well, we are absolutely going to have you on the show again just to talk about it, because that's a whole show in and of itself when you really think about it.
It really is a lack. There's a really big lack, and I see that. And once I've been with these guys, I see it, and I'm just amazed at how well they do their work and how passionate they are, and how we've I've come into this position and I'm able to back them up and just have them do what they do, and they do it very well, and I know this insurance and medical background, how to work the system, and I'm happy to help anybody that I come across. Even if I say it, just call me just for a question, I could look into it for you, anything. So it's definitely needed out there, so I'm more than happy to help.
And you know what, everybody listening, definitely go to thestrokechannel.tv or call our hotline number, which I know has been given out during the show, during the commercial breaks. You can call in and you can actually ask a question for Yesenia, so that the next time we have her on the show, she can actually address your personal question, because I know that there's probably many.
I just wanted to add something.
Sure.
When you were asking about education, it is absolutely the most kind of the failure of treating stroke right now is education. And there's been some studies, just to throw out some other statistics for stroke. African American are twice as likely to have a stroke as Caucasians, but they're less likely to be able to identify the symptoms of stroke on surveys. Hispanic women, the leading cause of death in Hispanic women is stroke, but they're less likely to be able to identify the symptoms of stroke on surveys. So you hit it right on the nail. The education is absolutely the most important.
Where do you think would be best to go into that mission field? High schools?
That's a
colleges?
great. You tell me. I'd like to know. What Yesenia and I have been doing, we were very fortunate enough to meet some people with one of the Spanish radio stations as well, and so we've given a talk there, and we've been going to some fairs. We've given some talks at high schools. A couple weeks ago, I spent an entire week giving talks to the fire departments, and so we're looking for more of these outreaches. I think this is a great one. I think community centers is a great one.
We just added one more. We have the Wilmington Farmers Market in the South Bay, predominantly more, low-income families. We want to start educating the Hispanic community, and it's all just teaching them how to eat healthier. Just to come out to the farmers market. It's in Wilmington, near the rec center. It's with Providence, so they're there every Tuesday, and we're gonna try to go out there and just try to give free flu shots, free blood pressure checks. So we're doing that just to go to the moms, the females, and I think especially in that community, Hispanic women, which is something that I've learned from them, all these statistics, and I'm like, it can't be. We have to do something about it. So we're doing that slowly but surely, and that's out there for the community.
That's something else that we haven't even really touched upon is diet, and which is something we'll touch upon in all this series of shows that we're doing, of course, but just in this conversation alone. Let's go around the table if anybody has any more questions, and then we'll go for a final wrap up with the doctor. And
I was wondering what age groups should be educated first. It's very similar to John's question.
You asked a question for John now?
Yeah, so the short answer is all age groups. We certainly want to educate the target, the patients that are at the highest risk of these, but in reality, we can't stop there. We have to educate the young patients who are going to be the family members that recognize, like John's son Evan did. We need to, middle-aged people who are at their office, and they have a colleague that's all of a sudden starts to have symptoms. So really every age group, and that's kind of something that we've been struggling with when we're trying to target some of these marketing. Well, what group do we target? Everybody. Everybody needs to be targeted by this.
But you have to start someplace.
You have to start someplace. So that's right. So what we're trying to do is get out to more things like this and really get to kind of, the middle age group before they're at risk for a stroke, to be able to recognize their parents having strokes and so forth.
If you're a stroke survivor and you're listening to this, I would suggest, if at all possible, try to find a stroke support group around you. That's probably one of the best ways to get information about your recovery and about your mental health, things like that. Because as a survivor myself, I wanted to find a support group, and I couldn't find one for over a year, and I looked everywhere. So hopefully, I think on the website, maybe we could put a list of support groups. Actually, there's a national support group list from, I think it's the National Strokes. I don't know what it is. I have to find out.
Well, I know that I couldn't find one when I was in the hospital, so I just started my own. So it's called strokesupportgroups.com. So, and there wasn't, because if I could get the .com for that, I was like, geez, you mean I can even get this .com? That's even available? Why is that even available? So, anyway, strokesupportgroups.com is the site that we have through the stroke channel.tv. And so, if you don't see one listed there in your area, and you know of one in your area, let us know about it so we can tell everybody else about it and have it listed there too. So that's my jokingly way of saying, if you know of a support group in your area, let us know about it so we can let others know about it too. And Gilbert, that's an excellent advice to give to them, because I know it's certainly helped all of us here through being a part of it. And that's the reason why this show exists, is that if somebody doesn't have access to one, at least they got this. Because everybody listening, you're part of this support group. You might as well be sitting here like everybody else is sitting here. It's just that you get to be in the comfort of your own home or wherever you're at, and you get to go to the refrigerator and everything else. We're sitting here. I got donuts and water over here at least, but yeah, absolutely. Great advice. John, you want to say something?
I was in Huntington Hospital first, and I go there a lot for therapies, and then I go in the stroke center and talk to them. Okay,
Wonderful.
but Casa Colinas is a good one for you, and I know it well for stroke stuff. I went to that 3 weeks, and it was good, and now I'm driving and stuff, and I went by them and talked to them, and speech therapy one, it was better and better for me, and
that's great.
it was good stuff.
That's great. How long after your stroke, when your stroke happened, how long was it that you did not speak?
Oh, yeah. Wow.
6 months? Year? Longer? Shorter?
Year, maybe.
A year.
Yeah. But it's getting better and better.
Yeah. Oh, that's great, man. That's great. That's great. Doc, final thoughts?
Yes. So I think, as you mentioned, you weren't talking for a year and you continued to progress. I think it's important not to give up hope. Once the stroke has occurred, it's very frustrating for both the patient and the family to go through the recovery period. And really, from that point on, all the work is on the family and the patient, and you just got to continue to fight. So I would say don't give up hope right away. Continue with the rehabilitation. Find the support groups. Reach out to us if we can help. We're here. That's what we're here for. And really educate yourselves both on identifying the stroke, how to get to the best hospital, and how to get the best recovery.
Absolutely. Absolutely. Well, Doc, thanks so much for being a part of things here today, and I know we're going to have you back again and
Please
again.
do.
And again.
We're very happy to. Thank you for having us.
I'm crazy about you, and there's nothing you can do about it. So just that's it. You're
Thank
on
you.
the team now, and same thing with you, Yesenia. We're definitely going to have you come back. We've been talking with Dr. Robert Darflinger as well as Yesenia Cuevas, and this is why we do this, you guys. This is why we have the Life After Stroke support group and radio show, is to kind of bring this information to all of you who may not have access to it. Do what you want with it, but really reach out to hospitals in your area to find out if there's a support group in your area. If there isn't one, start one. Just do your thing. That's what I did, because I'm in the hospital, couldn't find one. I'm just going to start my own, and there's other great support groups all over the place. But definitely be a part of one. So anyway, I thank you guys for listening, and we'll be back again next week with more of this. And until then, remember that there is still a beautiful life after stroke. This has been a recorded program of an actual stroke support group. The comments expressed are the opinions of the participants and not necessarily the opinions of the producers, sponsors, or the broadcasters of this show. This program is not to be used as a way to diagnose or treat any medical condition that you may have. Please consult your doctor or healthcare professional before making any changes to your current medical routine.